Welcome, curious minds, to another deep dive. Today, we're plunging into a topic that, well, it affects hundreds of thousands of people every year, often after what seem like pretty routine procedures. Nerve injuries. Specifically, we're talking about those incredibly delicate nerves that give us sensation in our face and mouth, the trigeminal nerve. Okay, let's unpack this. We've sifted through quite a stack of detailed sources here, surgical guidelines, research papers, the whole lot. Our mission is really to arm you with the essential insights. What are these trigeminal nerve injuries? Why do they happen? How do doctors figure out the damage? And importantly, what are the precise, often microscopic treatments out there to help people regain sensation, regain their quality of life? It's a journey into, well, the surprisingly vulnerable yet also resilient world of our nervous system.
You've hit on something really crucial there, the surprising prevalence is.
Yeah.
It's quite fascinating. Imagine something as fundamental as feeling your lip or, tasting your food, maybe just speaking comfortably. And that being impacted by procedures, many of us, well, we just take them for granted. We're focusing mostly on the trigeminal nerve's main branches down in the jaw and tongue. That's the inferior alveolar nerve, the EAN, and the lingual nerve, or LN. Injuries here can range from, just temporary numbness to really quite unpleasant long-term sensations that can profoundly affect someone's daily life.
And profoundly affect, I mean, that's not an exaggeration at all, is it? Just imagine, not being able to feel your lip or your tongue. Think about eating, drinking, speaking, even something like a kiss. It's so fundamental to how we experience the world. The trigeminal nerve is this amazing sensory powerhouse for your entire face and mouth. You could think of it like a complex electrical cable, maybe, for your face. And when one of those wires gets pinched or stretched or even cut, things can absolutely go haywire.
That cable analogy is perfect, actually. And if we look inside that cable, it's not just one big wire. Not at all. It's actually a bundle of many, many tiny individual strands, each with its own protective layers. We call this structure polyfascicular, lots of fascicles or bundles. Now, this structure gives the nerve some resilience, to minor bumps or maybe a needle passing through, but it also makes incredibly precise repair. Well, incredibly challenging, because you're trying to reconnect all those tiny individual strands you see. And these nerves, the EAN and LN, they're particularly vulnerable just because they run so close to so many common surgical sites, right there in the mouth and face.
So, okay, that leads us right to the big question. Where do these injuries actually come from? Because when we hear nerve damage, I think most of us probably think of major trauma, right? Like a car accident or something severe. But our sources, they reveal a pretty surprising truth, don't they? The overwhelming majority. They happen after routine oral and maxillofacial surgical procedures.
That's absolutely right. The most common culprit by far is third molar surgery, wisdom tooth removal. It accounts for a huge percentage of both AN and LN injuries. But other procedures can also put these nerves at risk. Things like corrective jaw surgery, dental implant placement, even certain root canal treatments, sometimes facial trauma repair. It really highlights how these vital nerves are often, well, kind of in the line of fire during everyday dental and surgical work.
Yeah, it's a bit unsettling hearing how common these procedures are. Can you give us maybe a sense of just how prevalent these injuries are, statistically speaking? Because common can mean different things.
That's a very fair point. While these procedures are routine, the risk, although small percentage-wise, is significant enough that it needs serious attention. So, for example, EAN injury from wisdom tooth surgery, the rates reported can range from, say, 0.4% up to maybe 7 to 0.5%. And for the lingual nerve, the LN, it could be from 0.06%, maybe up to 11.5%. So quite a range. For more complex jaw surgeries like sagittal split osteotomies, temporary numbness, that can be really high, maybe 80 to 100% initially. But permanent injury rates there are much lower, usually less than 1% to maybe 5%. These injuries can happen during, well, almost any phase of a surgery. It could be the initial local anesthetic injection, the incision itself using drills near the nerve, how the tooth is elevated or removed, even socket curettage or suturing afterwards. Lots of factors play a role too. Things like the patient's age, the specific position and depth of the tooth, how much bone needs to be removed, even things like chronic infection around the tooth beforehand. And yeah, surgeon experience can also be a factor. Nowadays, modern imaging like CT scans has really improved our ability to assess that risk before surgery.
You mentioned local anesthetic injections there. I know those are incredibly common, millions given every day. What's the actual likelihood of an injection itself causing nerve damage? Is that a big contributor?
It's definitely less frequent than surgical causes, but yes, local anesthetic injections are a known risk. The estimates vary quite a bit, but generally it's thought to be around 1 in 100,000 to maybe 1 in 500,000 injections. Though some studies looking closely at nerve blocks have suggested maybe higher rates of temporary issues, maybe around 3.6% temporary, 1.8% long-term in one study. The actual needle directly hitting and damaging the nerve, that's generally considered unlikely. Given that polyfascicular structure we talked about, the nerve is pretty resilient to just a needle prick. More often, the theories involve maybe the anesthetic solution itself being toxic to the nerve tissue. Certain anesthetics like prilocaine and articaine have been implicated more often. Or perhaps localized bleeding around the nerve, creating pressure like a small hematoma. There's even a needle barb theory, but this raises an important question, right, for the clinicians. How do you even begin to tell if the numbness came from the injection or from the surgical procedure itself when the symptoms can feel so similar afterwards?
Yeah, that's a critical challenge, I imagine. So, knowing how these delicate nerves can get injured, the immediate question for anyone experiencing this, or for the doctors, must be, okay, how bad is it? Because, as we're about to get into, not all nerve damage is created equal, right? What are the main ways doctors classify these different levels of injury?
Exactly. Understanding the degree of damage is absolutely crucial. It helps predict recovery, guides treatment. We primarily use two main classification systems, Seddon and Sunderland, but maybe the simplest way to think about it is in three broad categories. It's based on how much of that electrical cable we talked about has been compromised. So number one, neuropraxia. This is the mildest form. It's like a temporary stun of the nerve, a conduction block. The nerve fibers themselves are intact, but the signal isn't getting through properly for a while. Recovery here is usually rapid and complete, typically days, maybe weeks, like your foot falling asleep, then waking up.
Okay, that sounds like the best case scenario, relatively speaking.
It is. Then number two, axonotmesis. This signifies increasing damage to the actual nerve fibers, the axons. Those internal wires are damaged. But some of the outer protective coverings, like the perineurium or epineurium, might still be intact, depending on the severity. Recovery here is slower. It takes weeks, often months, and it frequently isn't complete. The more severe the axonotmesis, Sunderland breaks this down into second, third, and fourth degrees, the less likely a full recovery is.
Right, so damage to the wires, but maybe the outer casing is partly okay?
Kind of, yes. And then the third main category, neuromesis. This is the most severe. It means the nerve has been completely severed. That electrical cable is cut right through. Spontaneous recovery here is highly unlikely. And this type of injury often leads to the tangled mass of nerve sprouts trying and failing to regrow properly. We call that a neuroma.
You mentioned neuroma formation. Can you just quickly explain what that actually feels like for someone? Is it just numbness?
Oh no, often it's the opposite of just numbness. A neuroma is essentially this disorganized ball of nerve fibers.
Yeah.
They're trying to regenerate, trying to find a way back, but they can't reconnect properly. So for a patient, it can be a source of significant, often quite intense pain, or highly unpleasant sensations like burning, electric shocks, often in an area that might otherwise feel numb. It's the nerve's attempt to heal gone wrong, essentially creating more problems.
Wow. Okay. So with all these varying degrees of injury, how does a patient even describe what they're feeling? You hear about numbness, sure, but also pins and needles, maybe a crawling sensation, or even that awful burning feeling. And there's specific medical language for these different sensations, isn't there?
Yes, absolutely. Capturing the patient's subjective experience is paramount. We use specific terms like paresthesia. That's an abnormal sensation, but one that's not necessarily unpleasant, like tingling, pins and needles, maybe itching. Then there's dysesthesia. This is an abnormal sensation that is unpleasant. Things like burning, stinging, shooting pains. This is often the most distressing for patients. Hypoesthesia. That simply means decreased sensitivity. Things feel dull or less sharp. Hyperesthesia. That's increased sensitivity, where even light touch might feel uncomfortable or exaggerated. And then there's a particularly cruel one, anesthesia dolorosa. Imagine feeling intense pain, like burning or aching, in a part of your face that is actually completely numb to touch. It's a very real and incredibly difficult experience.
That sounds truly awful. It brings us to a really interesting challenge, though, and I imagine a frustrating one for patients sometimes. How do doctors objectively measure something that feels so deeply personal and subjective, like pins and needles or a burning sensation? How do you put a number on that?
That's exactly where clinical neurosensory testing, or CNT, comes in. It's a standardized process. It combines what the patient tells us their subjective report with objective physical measurements. We use questionnaires like the McGill Pain Questionnaire or visual analog scales to help track their pain and discomfort levels over time. But we also perform a series of physical tests right there on the affected area of the face or tongue. These objective tests, they follow a kind of step-by-step approach. We're testing different types of nerve fibers, from most sensitive to most resilient. So level A testing looks at the large myelinated fibers. These are usually the first affected by injury. We test things like sensing the direction of a brush stroke or telling if they're being touched by 1 point or 2 points close together, that static 2-point discrimination. If those are normal, it often suggests a pretty mild injury, maybe just that neurapraxia we discussed.
Okay, so you start with the most delicate functions.
Exactly. If level A tests show deficits, we move to level B. This involves using tiny calibrated monofilaments. They look like fishing line to detect lighter levels of contact pressure. Testing different nerve fibers, A-beta fibers. And then, if needed, we move to level C. This tests the small, tough fibers, A-delta and C fibers that are most resistant to injury. Here we test things like pinprick sensation, differentiating sharp from dull, and thermal discrimination, can they feel cold, like from an ice cube or ethyl chloride spray. By carefully assessing which sensations are lost or altered using this kind of dropout algorithm, we can get a much clearer, more objective picture of the extent of nerve damage. We can even correlate these findings roughly to those Sunderland grades of injury. And it's really important because sometimes what a patient reports subjectively, maybe saying it feels a bit numb, can sometimes be much less severe than what these objective tests actually reveal about the underlying nerve function. There can be quite a discrepancy.
That's a really clever way to get an objective handle on it. What about testing taste, though? You mentioned the lingual nerve involves taste. Is that part of the standard testing?
It is, but taste testing is tricky. Taste perception is incredibly complex. It actually involves several different nerves, not just the lingual branch of the trigeminal. So testing taste doesn't always give a clear correlation with how severely the lingual nerve itself is injured in terms of its general sensation function. You can have a significant lingual nerve injury affecting touch and pain, but the patient might not report much taste alteration, or vice versa sometimes. We also sometimes use a test called Tinel sign. That's where tapping gently along the path of a nerve might elicit a tingling sensation distally. It can suggest some nerve regeneration is happening, but honestly, it's not a very reliable predictor of whether good functional recovery will actually occur. And sometimes diagnostic nerve blocks with low concentrations of local anesthetic can be helpful. They can help pinpoint the source of pain or maybe predict how a patient might respond to certain treatments by temporarily blocking specific nerve fiber types.
Okay, so once a doctor has built up this accurate picture of the injury using the patient's story and all the sophisticated tests, the next and probably most crucial question for the patient must be, right, what can we actually do about this? Does it always lead to surgery, or are there other pathways to healing first?
Fortunately, no, surgery isn't always needed. And that's a key point. The majority of these trigeminal nerve injuries actually undergo spontaneous neurosensory recovery. They heal on their own, over time, without intervention. So for many patients, observation and reassurance is the first step. Now, for patients experiencing that unpleasant dysesthesia or persistent neuropathic pain, the first-line treatment is usually pharmacologic therapy. This is often managed with the help of a neurologist or pain specialist. It can involve systemic medications, things like certain antidepressants or anticonvulsants like gabapentin or pregabalin, sometimes muscle relaxants, and also topical medications applied directly to the area, like lidocaine gels or capsaicin cream. Sometimes short courses of corticosteroids might be used right after an injury occurs, perioperatively. The idea is to decrease inflammation and swelling around the nerve. The evidence for this is a bit limited, but some surgeons feel it's worth trying, and it's really important to reiterate. Microneurosurgery is generally considered a poor option, or at least not the first option, for nerve injuries caused purely by injections. Those tend to be more diffuse injuries, harder to localize surgically, and often have a strong dysesthesia or pain component that surgery might not help or could even worsen. There are older techniques, neuroablative things like radiofrequency or cryoneurolysis, but they have risks and pain can recur. And newer things like low-level laser therapy are being investigated, seem promising maybe, but aren't really standard of care or FDA approved yet for this.
Okay, so medication and watchful waiting are key first steps. But if surgery is considered, what's the trigger? What makes a doctor say, okay, now it's time to think about microneurosurgery? And you mentioned timing earlier. How critical is that?
Right. Microneurosurgery generally comes into play for a few key reasons. One is persistent hypoesthesia or anesthesia, basically numbness, that just isn't showing any signs of improvement after a reasonable observation period, say around 4 weeks post-injury. Another clear indication is if a patient has complete loss of sensation, total anesthesia, right after the surgery. That suggests a likely significant injury, maybe even a transection. Or, importantly, if that unpleasant dysesthesia starts to develop or worsen over time. That can actually be an early sign that a painful neuroma is forming. And here's where it gets really important, as you said. Time is absolutely the most critical factor. Timing is everything in nerve repair. Why? Well, a few reasons. First, When a nerve is injured, the part disconnected from the brain and spinal cord starts to degenerate. It's called Wallerian degeneration. It basically dies back. This means the gap between the healthy nerve ends actually gets bigger over time. The longer you wait, the more nerve tissue is lost, and the larger the gap the surgeon has to bridge. Second, surprisingly quickly after injury, some of the original nerve cell bodies back in the ganglion can actually die off, maybe up to 50% within weeks to months. Fewer cells mean less potential for recovery. And third, as we touched on, the brain itself starts to adapt to the lack of input. That cortical somatosensory reorganization, the brain essentially rewires itself. And sometimes this rewiring can lead to the brain interpreting the lack of normal sensation, the numbness, as pain or dysesthesia, like a phantom limb type of phenomenon.
Wow. So the clock is really ticking on multiple fronts: the nerve itself, the cell bodies, and even the brain.
Exactly. So because of all these factors, there are generally recommended timeframes for surgical intervention, if it's going to be done. For the lingual nerve, LN, the ideal window is generally considered to be within 1 to 3 months after the injury. For the inferior alveolar nerve, AN, because it has that bony canal protection we mentioned, we can afford to wait a bit longer to see if spontaneous recovery happens. So the window is typically 3 to 6 months.
That makes sense about the IN having that bony canal as a guide. It connects back to the anatomy. So, okay, let's say the decision is made for surgery within that window. What does this incredibly delicate microneurosurgery actually involve? What happens in the operating room?
It's extremely precise work, usually done under an operating microscope with very fine instruments. The first step is exposure. The surgeon needs to carefully find and expose the injured segment of the nerve. This might be done through an incision inside the mouth, transoral, which avoids a facial scar but can be difficult for access, especially further back. Or sometimes, for better visibility and access, especially for the IN, a small incision might be made on the face or neck, transfacial or transcervical. Once the nerve is exposed, the next step is often neurolysis. That means carefully freeing the nerve from any surrounding scar tissue or adhesions that might be compressing or kinking it. This is external neurolysis. Sometimes, if the nerve looks okay externally but is swollen, the surgeon might consider internal neurolysis, which means carefully opening the outer layer, epineurium, and separating the bundles inside. But this is done very cautiously, as it risks further damage. Now, perhaps the most critical step of the entire operation is nerve stump preparation. The surgeon has to meticulously trim back the ends of the injured nerve, removing all the damaged, scarred, or neuromatous tissue. They keep trimming until they see healthy, glistening white nerve fascicles, sometimes described as mushrooming out slightly from the cut end. This indicates healthy tissue. This often means the resulting nerve gap becomes significantly larger than initially anticipated. You have to be aggressive here to get back to good nerve.
Right, you have to sacrifice some length to get to the healthy parts.
Precisely. Then comes approximation and coaptation. Approximation means bringing those prepared, healthy nerve ends together. The ideal goal is to do this without any tension. Tension is the enemy of nerve healing. Generally, for the IAN, a gap of less than 5 millimeters might allow for direct, tension-free repair. For the LN, maybe up to 10 millimeters. Coaptation means carefully aligning the fascicles, those bundles, within the nerve ends. This is really hard with these polyfascicular nerves trying to match up the bundles correctly. And finally, neurorography. That's the actual repair. Using incredibly fine sutures, usually 8-0 to 10-0 monofilament nylon that's much thinner than a human hair, the surgeon carefully stitches the outer protective layer, the epineurium, of the nerve ends together. Typically just 2 to 4 tiny sutures are needed.
That sounds unbelievably intricate. So what happens if that aggressive trimming, getting back to healthy tissue, creates a gap that's just too large? You can't bring the ends together without tension. What then?
That's a very common scenario, actually. And that's when we need to use nerve grafts or other bridging techniques. If a direct tension-free repair isn't possible, the surgeon needs to bridge that gap. The gold standard for many years has been an autogenous nerve graft. That means taking a piece of healthy nerve from somewhere else in the patient's own body. The most commonly used donor nerve is the sural nerve, which runs down the back of the calf. It's a good choice because its size often matches the IN or LN reasonably well. You can harvest quite a long piece if needed, up to 20 centimeters or more. And the sensory deficit left at the donor site, usually some numbness on the side of the foot, is generally well tolerated by patients. Another option sometimes considered is the greater auricular nerve from the neck, but it's often a poorer choice, smaller diameter, and the donor site morbidity on the face neck is less desirable. More recently, allogeneic nerve grafts have become available. These are FDA-approved processed cadaveric nerve grafts. They avoid the need for a second surgical site on the patient to harvest a nerve, and early results are showing quite promising outcomes. sometimes comparable to autografts. Another approach, though often with less predictable or robust outcomes, is intubulation. This involves placing a tiny conduit or tube across the nerve gap to try and guide the regenerating nerve fibers. These conduits can be made from various things: a piece of vein, collagen, muscle tissue, or synthetic resorbable materials. But clinical results are often not as good as with nerve grafts, especially for larger gaps.
Okay, grafts seem like the main solution for bigger gaps. And after all that intricate surgery, what happens next for the patient? Is recovery immediate?
Oh, definitely not immediate. Nerve regeneration is a slow biological process. After surgery, patients often begin sensory re-education exercises. This is almost like biofeedback. As sensation starts to return, which can feel weird or different at first, these exercises help the patient's brain relearn how to interpret those new signals correctly. Things like identifying textures, temperatures, shapes with their lip or tongue. And everyone needs to understand the rate of nerve regeneration. It's roughly 1 millimeter per day, or maybe about an inch, 3 centimeters per month, under ideal conditions. So depending on the length of the injury and any graft used, it can take many months, even up to a year more, to see the final extent of recovery. It requires significant time and patience from both the patient and the surgeon.
That's an incredible amount of precision and patience needed all around. But let's talk about the bottom line, the outcomes. What are the overall success rates? Is microneurosurgery a magic bullet that completely restores normal sensation?
That's a really crucial question, and managing expectations is key here. Reported success rates in the literature, they do vary quite a bit. You see figures ranging from maybe 30% to 50% overall improvement in some older studies. But one large, well-conducted study reported meaningful functional sensory recovery in about 76% of their patients, based on specific objective criteria. So it can be quite successful. However, it's very rare for a patient undergoing microneurosurgery to achieve completely normal pre-injury sensation. That's usually not a realistic goal. But, and this is important, the majority of patients in most studies still considered the surgery worthwhile. They felt it significantly improved their functional ability. Eating, speaking, things like that, and their overall quality of life, even if some numbness or altered sensation remained. What we consistently see in the data is that injuries causing mainly hypoesthesia, just decreased sensation, tend to improve more predictably with surgery than injuries dominated by hyperesthesia or dysesthesia, those unpleasant, painful sensations. Those are harder to treat surgically.
We also see that lingual nerve repairs tend to have somewhat better recovery outcomes than inferior alveolar nerve repairs, possibly due to anatomical differences in blood supply. And crucially, as we've emphasized, delaying the repair significantly, especially beyond 6 months to a year, definitely decreases the overall chance of a successful outcome. There's still a real need for more standardization in how we evaluate patients before and after surgery, and how we report outcomes to get even clearer data.
That makes sense. Improvement, not necessarily perfection, is often the goal. And stepping back a bit, beyond just the clinical outcomes, there are pretty significant practical and even legal implications surrounding these injuries, aren't there?
Absolutely. Unfortunately, nerve injuries, particularly AN and LN injuries related to third molar surgery and implants, account for a really large proportion of malpractice claims in the field of oral and maxillofacial surgery. It's a major medical legal issue. Because of this, there are certain sort of legal parameters of care that surgeons are expected to follow. This really emphasizes the need for meticulous documentation of the preoperative assessment, the surgical procedure, and any postoperative findings. Clear classification of the type and severity of the injury is important. And crucially, prompt referral to a specialist with experience in microneurosurgery is essential, especially if a nerve transaction is suspected or observed during surgery, or its symptoms are severe or persistent. And as we discussed, that principle of early surgical intervention, ideally within that 3 to 4 month window for LN, maybe 3 to 6 for AN, has been shown repeatedly to be more effective than delaying treatment beyond a year. It is also vital for everyone, patients and clinicians, to understand that while surgery is more likely to improve objective sensory testing results and reduce functional impairment, it is often less likely to completely eliminate subjective numbness or especially pre-existing pain of dysesthesia. This means that appropriate, detailed, informed consent before any surgery is absolutely vital. Patients need to understand the realistic potential benefits, the significant limitations, and the possible risks of these intricate procedures.
This deep dive has truly shone a light on the incredible complexity, hasn't it, and the delicate nature of our body's wiring, especially that trigeminal nerve. It's quite astounding how common these injuries can potentially be, often stemming from procedures we think of as routine. Yet there's this fascinating and rapidly evolving science behind understanding them, diagnosing them, treating them. From the body's own amazing capacity for spontaneous recovery in many cases, to the highly specialized microscopic world of microneurosurgery. The path to healing is clearly rarely simple, but it seems like it's always guided by a deep understanding of neurobiology and, critically, that careful, timely intervention.
It really is. And this raises an important question looking forward. As technology continues to advance, think about imaging, surgical instrumentation, maybe even our understanding of nerve growth factors and biomaterials. And as surgical techniques continue to be refined, how will these intricate procedures continue to evolve? What might the future hold for truly, reliably rewiring the human body after these kinds of delicate injuries? Can we offer even more complete, more predictable outcomes for patients down the line? It's an active area of research.
Definitely food for thought, an area to watch. Well, thank you for diving deep with us today into this complex world, and thank you, our listeners. Keep learning and stay curious.